Thank you so much. Well, thank you everyone for coming. Thank you. It's never probably exciting to talk about death on a Tuesday, but I really hope this conversation is more about living well. And because dying well, I think, is mostly about living well. So I'm so thankful to have met you, Joanne, and just really grateful for the invitation as well. I think it's an important topic, and one that you probably might have talked about before, or even when you moved to East Castle, you're asked about advanced directive, you're asked about DNR orders. So this might feel familiar to many of you. And so I'm really hoping this is more of a conversation. I'd love to learn from you all and kind of gather your collective wisdom from each other on a few things, kind of advanced care planning broadly, but I want to give you some specific information about DNR orders just as a refresher for some of you, or maybe some things you didn't know about resuscitation. Because again, I think education is empowering. The more you know, the better informed you can be, the better types of decisions you can make. And again, that's about living well. So that's what I really hope to do today. And then again, I'd love to hear from you on how do you have these hard conversations? How do you talk to family and friends about the sort of decisions that you would make or would not want to make? It can be hard, it can be uncomfortable. So I want to hear from you all what's worked well, what hasn't, and really keep it open and informal. So please feel free to interject, raise your hand with questions throughout. I'd love to hear from you. So we'll go ahead and get started with just some basic information that I know all of you are familiar with. Just raise your hands. How many of you have an advanced directive? And I mean that broadly. Almost everyone. I would say, bravo, you're way ahead of the American average. I think the room was maybe at 100%. About 36% of Americans have an advanced directive. So it's even lower for specific living wills and lower for power of attorneys specifically. So you are already, again, very well educated and very much ahead of the average population. But I want to just, again, give you a bit more information of what I mean when I talk about advanced directive and advanced care planning broadly. And then we can kind of drill down into a few more specifics as well. So again, when I say advanced directive, I really just mean that legal document that you create when you have decision-making capacity. And I'll talk more about what I mean by decision-making capacity. That communicates your treatment preferences should you, for some reason, become incapacitated. And it has two components, right? So there's that living will part that says, I kind of call it the menu, right? Of this is what I want, this is what I don't want. And then there's the healthcare power of attorney. So that is the specific person or surrogate or alternate surrogate that you would choose to make decisions for you if you can't. And I'll give you my big takeaway from the talk today. There's a couple, right? It's more about living. Second takeaway, I really favor healthcare power of attorney. Living wills have a purpose and they can be good, but the surrogate is, I'd say, most important. And having conversations with your surrogate is most important. So that's my big takeaway from the day, number 2. It's about living well, and please have a surrogate and talk to them about what you want. So that's right off the top. No surprise ending. But when I talk about decision-making for incapacitated patients, this means, again, you're no longer able to decide for yourself. So to have capacity, we usually say, okay, well, you need to be able to understand the decision at hand. You need to be able to appreciate that it applies to you. You could say, yeah, I logically understand that this is a risk and this is a benefit, but can you apply that to you personally? That's appreciation. Can you reason about it? Can you say, yep, these are the risks, these are the benefits, and can you express a choice? So of course, if you are sedated or unconscious and can't express a choice, we would go to your living will or your surrogate. And this is how we do this. So you might actually not know when you come into the hospital, and maybe, again, you are unconscious, you're not able to communicate. And I apologize in the back if it's hard to see, and I'll try to read as much as possible too. And I'll also send out the slides after as well, so you can get a copy of these. But when you come in and are not able to speak for yourself, this is actually how your care team makes decisions. So first of all, we go with what we know. Do you have that advanced directive or that living will that says, I want X, Y, and Z, I don't want A, B, or C? So that's what we do first. What do we know? What can we assess? And what can we find out? Then, if we don't have known wishes, we say, okay, do you have a surrogate who you've appointed as your power of attorney? We want them to be able to make decisions for you based on what you would want. So we call that substituted judgment. So I'm the surrogate, I'm putting myself in the patient's shoes. I'm trying to decide what she or he would want. or decide if they were able to make that decision right now. So it's not saying, oh, I would want this, so I'm gonna make this decision for my mom. It's, no, this is what my mom would want, I'm gonna substitute my judgment for hers, and that is kind of the next step that we go to. If we don't have any of those, if we don't know what you would want, if maybe your surrogate doesn't know what you would want, or your surrogate is feeling overwhelmed, then we go to what we call best interest. We just say, okay, well, what's just best for this patient in this circumstance right now? And that gets tricky too, right? Because best means different things to different people. Sometimes in healthcare, I'd say, you know, I do a lot of pediatric bioethics, and so we always want to do what's best for the child, but sometimes we do what's good enough, and that is okay too, given healthcare resource constraints or constraints of your condition, your illness. Sometimes best just isn't possible, so we have to do good enough. So this is a hard one when we get to kind of the third step in the hierarchy. Okay, we still want to do what's best for you, but what does that really mean if you haven't had those kind of goals of care or values conversations with a surrogate? It can get a little muddy. So this is how we would be making decisions for you if you did come in incapacitated. Yeah, Dave.
Does best in the medical system usually mean keeping the person alive?
Excellent question.
Can you repeat?
I can. He asked, does best in the medical system usually mean keeping people alive? And I would say for many people, yes. I would say for patients and families especially. I think a lot of patients and families think, of course, living is better than dying. Best means doing everything. I think a lot of healthcare providers have seen what doing everything means, and it can actually be very harmful. And we're going to talk a little bit about that today too. And so I think they know that best isn't always life. But that's a big value question that you would want to talk about with your surrogate, with your friends and family, to decide what does best look like for you.
When you have these documents in place, and of course aren't these pro forma state of Wisconsin documents, will all healthcare providers honor your documents?
Good question. So the question was, will all healthcare providers honor your documents? Yes, absolutely. And we're going to get into some of the, not the reasons why they wouldn't, but the complications with the forms, or forms in general, or advanced care planning in general. There's always things that make it tricky to make that happen. But yes, legally, those are recognized documents. When you're coming into a hospital, people ask, do you have an advanced care directive? What are your wishes? So legally, they are recognized across the state. Good question. Yeah.
In my experience, I think that choosing your surrogate is one of the most important things you can do.
Absolutely.
Because in our family, my sister couldn't do it.
Couldn't do it. Yeah.
And she was the only one there.
Yeah, that is a great point. And we're going to talk more about that at the end. I'd love to kind of hear, how do you choose a surrogate? What does a good surrogate look like? Because I think that is actually a really important part of the advanced care planning. They have to be a little tough. Yeah.
If your current documents are from another state, should you have them updated when you move? Like, I just moved here.
Good question. So the question is, should you have your documents updated from another state? It's always best practice to make sure that they're updated.
What if they weren't though? What
if they weren't, as long as your provider has a copy,
okay,
and they're in your medical record, and it was notarized appropriately in that state, they should be, you know, maybe not, oh, like this is law, this is legal, but they're going to look to that for guidance.
Okay.
Absolutely. So it's better than nothing.
Yeah.
I would say, for sure. The other thing, a small caveat on forms, it's always a good idea, you know, to keep those updated. You know, for example, if you were divorced and your surrogate was your spouse, that actually gets invalidated, and then you need a new one. Doesn't mean your ex can still be your power of attorney, but you just need to say, yeah, I know we're not married anymore, but I still want them to make decisions for me, which we've actually seen before. So there's a couple things that you just want to make sure your forms are up to date as much as possible. Yeah, good questions. Good questions, and we'll talk more about the forms as well. So a couple of benefits of advanced directives, and I know many of you already know about advanced directives, so I'm going to get mostly to the DNR, CPR part of things in a minute. But again, just a brief intro here. we think advanced care planning is a good thing. We know there's benefits to it, and this is why we do education like this, why we want to have continued conversations, because we really want to make sure that your goals are respected. That is the goal of advanced care planning. It might seem like physicians or your healthcare team has an idea of what they want to do going in, but I think, assuming the best out of our providers, we want to do what makes medical sense, but what also makes sense for your goals and values. And we try to do that as much as possible. And when I say me, I'm not a physician, but I work with healthcare teams, and especially trying to respect your choices. And so I think that's one of the major benefits of an advanced directive. We also just want to make sure that you're satisfied with your care, right? Not in a patient satisfaction sense, but you need to feel good about what's being done to you, what's being done for you, and having these conversations early and often is actually the best way to do that. So when you are confronted with a medical emergency or a medical illness, you're prepared. You feel a little bit more ready as you ever can be. You're never quite ready, right? But there's a little bit of comfort in knowing you've taken that step. We also actually want to decrease conflict among your loved ones or your surrogate and the providers, right? Family actually say, we have better communication with the physician, with the care team, if there's an advanced directive in place. And I'll talk more about this as well, but even to your point about surrogates have to be tough, sometimes surrogates say, I can't let her die, right? Or I have to do everything, she's a fighter. But what does that mean, right? And do you think she's a fighter, or does she say she's a fighter? And what does fighting look like, right? That's a metaphor we hear commonly, but dig into that a little bit, right? What do you mean when you say you're a fighter? Or what do you mean when you say, well, my dad's a fighter? Because so much of that surrogate work is tough, and it's, can I be strong for my surrogate, for my loved one, for that patient when I need to be, and then actually decreases conflict. You might think the opposite, like, oh, I don't have any plans, and so, and we're going to talk more about this too, but the phrase, I'll let my family decide, right? This came up in our wellness committee. I'll let my family decide. That might actually be more harmful than helpful, and I think it comes from a good place. But when I say I'll let my family decide, I'm letting them flounder without guidance, without direction, and they can end up with a lot of guilt and shame. And there's been a lot of studies that show surrogates actually feel that guilt and that shame. So don't think you're being mean or demanding by saying, no, actually I don't want this, or I really do want that. That actually can be one of the most kind things you can do for yourself and for a surrogate. And then again, so just making our loved ones feel better about our decisions, I think that is a really important goal of advanced care planning. All right, now I want to get to the nitty-gritty a little bit of living wills. Any questions before I get into some of the challenges I see with living wills? But again, feel free to interrupt as I go. But so when I talk about living wills, I'm talking, this is the menu. So again, I love a surrogate. I think surrogate conversations are so important. I think living wills can have a place, especially so when you, for those of you that have the advanced directive form, it has those boxes. If X were to happen, I would or would not want A, B, and C. And so that's what I mean when I say the living will, the particular type of treatment that you want. So there's a couple things that you need for a living will like that to be successful. So first you have to have them, which again, you guys are the rock star group. You're the most when I've given this talk before, I don't think I've ever had 100%, so you're already ahead of the curve. Again, about 36% of Americans have a living will. It's lack of awareness. It's hard to talk about, especially, for younger populations. We say we don't need to think about dying, but this is for everyone. Advanced care planning is for everyone. And so I think that's just one of the biggest barriers that we have right now to living wills. This is an important one. People must know what they want. But I just don't think our choices are always stable. So there's an interesting study about women in childbirth. Their preferences for epidurals are very stable before childbirth. They're not so stable during childbirth. So circumstances change, preferences change, your choices are going to change. And so I think you don't actually always know what you want. It also depends on how choices are framed. And I think this is a point of education for you all as well. So there was an interesting study that had a group of elderly patients, and the physician presented an intervention. So first, the physician team presented the intervention negatively. So they said, this is the failure rate, or the, X amount of people died after this intervention. Only 12% of patients chose it. Then the physician team presented the intervention neutrally. Well, here's the success, here's the failure. About 18% of the patients chose it. Then the physician team presented it positively. So this is the success rate. 30% chose that intervention. 12% when it was presented negatively, 30% when it was presented positively. Same intervention, same for everyone, just the way it was framed completely changed how people interacted or decided about that decision. So that's not to say, that they made a bad or a good decision, but I think a couple things. First, we do a lot of education with our physician teams to make sure we're informing appropriately, but also you can ask. I hope this empowers you, right, to ask those questions and say, okay, doc, well, you gave me, the failure rate. Well, what's the success rate? Or, oh, wow, it's 30% success. That sounds great, but that means 70% failure, right? And sometimes just hearing it out loud, like, yeah, you can do the math in your head. Okay, well, you told me 30% success, 70% failure. Can you confirm that for me? Right? I think hearing that out loud, there's power in that. And so asking that question to make sure you get the whole frame is really powerful too. So again, your choices, lots goes into that choice that you're actually making. For living wills to be successful, people have to articulate what they want. So again, writing that down on a piece of paper actually is maybe a bit harder than it seems, because it's very difficult to anticipate your changing circumstances. I think the big ones that we talk about in advanced care planning are tube feedings, artificial nutrition hydration, and mechanical ventilation, intubation. And so, a lot of people say, I never want to be intubated, I don't want that tube down my throat, I never want that. What if you have a bout of pneumonia that your care team thinks is reversible, is treatable, you need to be intubated for a short time, but you will get back to baseline. But your advanced directive says never, ever, ever, no intubation. But your surrogate kind of knows you and says, well, I know she'd be able to get back home, get back to her baseline. I don't see why we wouldn't do this for something so, so circumspect. So do we listen to the advanced directive? Do we go with the physician team that says, oh, well, we really think this is short-term and temporary? It's hard to anticipate those changing circumstances, that nuance in a form. That's a conversation that you would have with your surrogate, right? Like, I don't care, I never want to be intubated. I don't care if I can, get back home in a few days. That might be a really strongly held value for you. But the form doesn't get to that. So that's where your surrogate might struggle a little bit. It's also hard to imagine how resilient you can be, right? I think in many ways there's sort of an ableist bias in our society. Oh, if I can't walk on my own or talk or eat on my own, if I can't feed myself, and I don't want to live like that. But we're resilient. And I think you all are resilient and live with changes and get accustomed to them, right? And you would say, oh, actually, my life was really worth living right now. I never thought it would be like this, or I didn't know I would have to overcome that challenge, but yeah, my life is absolutely worth living. And so I think we underestimate how resilient we are, what we're actually willing to live with or not. And so that's, again, very hard to put on a form. Again, I sound like I'm really hating on living wills, and they have a place. They are very important. So a takeaway is, yes, you can have a living will, but remember, takeaway, have a surrogate. Living wills have to be accessible. This is sort of a practical problem. 62% of people with advanced directives do not give them to their providers. They're in your bedside table. They're in a safety deposit box. They're in that pile of magazines next to your couch, right? And I think this is a practical problem that's understandable. I moved, I have to get a new form, I have to make sure it's signed and there's a witness, and then I have to bring it to my appointment and make sure it gets in the chart. But oh, what if I go to a different hospital and it's not in the same healthcare system? Then do I have to bring it there, right? So it's a lot. And I think this is just a practical consequence of that, making sure the form gets in the right place at the right time, in the right hands. And of course it's doable if you're diligent about it. Yeah, absolutely.
Any requirements for copies to be accepted?
Good question. Usually copies are fine as long as they have the witnesses, the appropriate signatures.
That would be a copy of the original.
A copy of the original, yeah, because even in the chart, they're gonna, scan in a copy, so you don't ever have to have the hard, physical, signed copy, on hand, so I would say,
Well, just a
Copies are fine.
notation here, I had 3 surgeries in 3 weeks at 3 hospitals, and I had this advanced directive, but of course they all got copies. Not like I was gonna run off and
Yeah.
get signatures again.
Yeah.
So, yeah, I
I
had a whole
checking.
pile made up, I've been using them for a couple of years.
so that's the other option, just make 100, and here, would you like an advanced directive, would you like an advanced? And give them out at Halloween, yeah, so I think that is absolutely a good point.
It might be, if you're giving them to multiple places, you may wanna keep a list of where you sent them, so if you
Yes.
change them, you know the ones that are out there that you wanna change.
Great
Because
point.
otherwise you'll forget.
Exactly, and so that's the hard part about, again, a form, when your decisions change, when you say, oh, I've actually lived with this and this doesn't bother me, or I've lived with this and this really bothers me. You have to kind of be constantly reevaluating your values and goals, which I think is a good thing, but it's more tedious to do as opposed to surrogate, call them up, hey, this thing happened, this change happened, put that in, just note that down for when we have to make decisions for me. So surrogates can be a little bit more flexible in that way.
What happens if you end up at a strange emergency ward, that you're traveling or even in the same community, they take you to a different hospital system?
Surrogate, that would be my go-to, right? And so if you're unconscious, say, if you show up incapacitated, they'll try to find next of kin, relatives, someone they can call, and then hopefully that person that they contact knows who your surrogate is, or is your surrogate. And then at that point, hopefully they can find your advanced directives. And our social workers, I would say, are amazing, and they can do a lot of sleuthing, so they actually might be able to connect with other healthcare facilities and find your advanced directive if they have one. Yeah. Other people who have experience with that might know more. Feel free to give your intake as well. But that would be my take again for the surrogate. Lastly, my last little caveat about the living will: decision makers have to be able to read the living will accurately. And I don't mean your handwriting, but can they interpret what you want? There's actually a very interesting study where they had a group of surrogates who had an advanced directive, a group of surrogates who didn't, made decisions. The patient recovered, and then they were actually able to ask the patient, oh, how did your surrogate do? 70% of the group that had an advanced directive made accurate predictions. Anyone know about the percentage that was correct without an advanced directive?
0.
70%.
Oh.
The same. So it's kind of chance as to whether or not your advanced directive is going to be interpreted appropriately. And again, these surrogates might have just been well informed about the patient, able to make those 70% predictions. So again, it's helpful to have. I mean, good, 70%. We're able to accurately decide what the patient would have wanted. But sometimes it's not any better than chance. So I thought that was pretty interesting. Any questions about the living will before I move on to DNR and resuscitation?
This doesn't, we have a power of attorney for healthcare. Is that what surrogate means?
Yes, apologies, that is exactly what it means. So healthcare power of attorney, when I say surrogate, I mean the same thing, yeah. And there's also, there's differences. So there's a guardian. A guardian is different than healthcare power of attorney. That's more all-encompassing, right? Finances and estate, things like that. So I'm not talking about guardianship or anything like that. This is just for decision-making in healthcare. Yeah, good question.
Just one quick question. If you have a situation where you've got the surrogate, she's a member of your family, there's another member of the family who either doesn't agree or would rather be the surrogate but is not named, who in the hospital handles those kinds of disputes?
Sometimes ethics committees, so sometimes, and I would get called in, sometimes pediatric, this happens as well, more in adult cases. But interestingly, Wisconsin is not a next of kin state. And by that I mean some states actually have laws that say, if you don't have an appointed surrogate in a healthcare power of attorney, legally written down, we go to your next of kin. So I think it's usually spouse, adult child, adult sibling, something like that. Wisconsin doesn't have that hierarchy. So we actually get into a lot of conflict when either no surrogate has been named, so which one takes priority,
Right.
because we don't have that hierarchy to help us. Or we have one who's the patient has named, but someone else is fighting with them. In that case, it's a little bit clearer because, hey, the patient has named this person as a surrogate. We're gonna listen to them. They have priority in a way here. When there's conflict, that's when I think we need to call our medical family therapist, and that actually just takes a lot of good communication work. Where again, sometimes it's the care team, sometimes it's the healthcare ethics consultant or committee that would meet with them, or a trusted nurse, even someone that can say, hey, I know this is hard. And I know you don't see eye to eye on what dad would want, but remember, this is about dad, and it's about what he would want. It kind of just that reframing is sometimes very helpful.
But there's somebody in that facility who has
Absolutely, absolutely. So yeah, there's no one that's gonna say, okay, well, we like your decision, so we're gonna choose you as a surrogate. I think it's tempting, or sometimes it's, well, this surrogate answers the phone and this one doesn't. So we're gonna go with that decision too. We really, those are the practical aspects, but I would say ethically and as a care team, we try to avoid that. We wanna work through the conflict with our patient's best interest in mind. I know this conflict is hard, you don't answer the phone, you do, but I wanna hear you both out. And so I'd say care conferences are really important at that point, and we do make an effort to resolve that conflict. I would also say, as a caveat too, it's sometimes we say, oh, I wish Wisconsin was a next of kin state. It would make things a little easier, but it's nice to remember that actually protects patients in a way too. Especially if there's a family member who's estranged or a child who doesn't talk to their parents, but I don't have a relationship with my parents, but they're my next of kin, so they'd be making medical decisions for me. That would feel unfair or maybe even unsafe to that patient. So I think that's one benefit of not having that kind of strict hierarchy in our state. So it makes it hard in some ways, better in others, but really it just goes back to make sure you know who your surrogate is, make sure the rest of your family knows who your surrogate is, and can respect that decision. Other questions? Yeah.
Maybe I misunderstood that question, but if you have a legal document and you've named a surrogate and someone doesn't agree, too bad. I mean, you've named a surrogate, so what's the?
Yeah, I agree.
Oh.
You're gonna follow that surrogate's wish. I think the thing is I would say a lot of healthcare facilities try to do family-centered care, right? To a point. And I would say I see this more probably in peds just because I do a lot of pediatric work, but we don't want to just let that conflict simmer. I think a lot of our healthcare teams do a good job of saying, okay, sister, I see that you don't agree with your brother who's a surrogate, but your dad has named him the surrogate. And so I think we try to do a little bit of that communication work, but not to the extent that we would say, oh, well, we need to listen to you just because you're putting up a fuss. Yeah, so you're gonna listen to that legally appointed surrogate,
Right.
And do what you can to get everyone else on board, I would say. To the extent possible. It doesn't always happen. Yeah. Yeah, was there? Yeah.
There is draft legislation, it's in the draft stage right now to make Wisconsin an next of kin state. And besides the problems you've already mentioned, there's that problem that person doesn't have the same power as a surrogate. For instance, if the surrogate knew that patient wouldn't want CPR, there's no CPR. But it's my understanding that guardian can't do that.
A guardian can't pick.
Can't say no CPR.
Right, and that goes back to another guardianship problem too.
Right,
Best
right. So
interest.
all the more
on
reason
side
to
of
have a
life.
surrogate. And
Exactly.
I do know of a physician that was in Minnesota, which is the next of kin state, that purposely did their advance directive prior to a procedure because they didn't want their mom stuck.
Yeah, that's interesting. And I think, again, it goes back to surrogate, the importance of our surrogate. So that'll be interesting to see where that lies. I'll come back next year. We'll have to do part 2 to see if there's some new updates on next of kin laws and surrogacy. Other questions? These are all really great. Okay, so this gets into, and again, I'm not medical, so any medical people out there, please feel free to correct me. But I do, again, just want to give you a little bit more information on what is DNR, DNAR, DNI, lots of letters. But what does resuscitation mean? What might it mean for you? What are some good conversations you can start to have with your healthcare providers and family and friends? Because this was a prompt for the conversation today. And I think it's one that we actually don't talk about enough. We talk about advanced care planning broadly, but DNR is just a small facet of that. but one I actually think that kind of gets glossed over a bit. So, show of hands, who's heard of DNR, DNAR, DNI? Yeah, I'd say most of you. So DNR just means do not resuscitate. And so this means if your heart were to stop beating or were to go into cardiac arrest, we want to start CPR. We intubate you to make sure you have a secure airway. We shock your heart back into a good rhythm. We give you drugs to support your heart as well. So there's actually a lot that goes into resuscitation. Some hospitals, you might have heard of DNAR. It's the same thing as a DNR, it just means do not attempt resuscitation, because that's what we're doing, right? We're really attempting resuscitation. DNR kind of sounds like it's gonna be successful no matter what, which we know is not the case. So DNAR, you might hear at some facilities as well, do not attempt resuscitation. You might have heard of DNI, which just means do not intubate. So sometimes your heart could be fine, but you could be having a respiratory emergency, or your airway could be compromised, you're not able to breathe, so your team might say, oh, we need to intubate you to make sure you can breathe, but that's not actually your heart. It's not actually a heart problem. And so you might say, well, I even if my heart's fine, I actually don't want to be intubated either. So this is a conversation that is a little bit nuanced, but you might actually want to have that conversation with your providers as well. So a couple things. So say at Freighter, where I am, I'm mainly at Children's, but a little bit at Freighter. You can't have do not resuscitate. You cannot have a do not intubate, but want to be resuscitated. Why is that? So resuscitation, when we say we're going to resuscitate you, we want to use all of our tools. So it's going to be, again, CPR, it's going to be shocks, it's going to be drugs, but intubation is a part of that toolkit. So if you say, all right, my heart has stopped, I want you to try to revive me, you're going to probably be intubated as part of that. So you can never have just a DNI, but please give me CPR. That wouldn't be kind of an allowable order, we would say. But you can say DNR, DNI. Yep, if my heart stops, don't do anything. But also, even if my heart is fine, but my breathing's not, I don't want that either. So that would be something that you could, again, have that conversation as well, that I really don't want to be intubated. So make sure you specify that as well.
When would that be reasonable?
A DNI?
Yeah.
I think it depends on the person. It depends on your values, on your goals, and probably your health, your current, what brought you into the hospital at that point. And hopefully your care team would be talking to you about that. I would say they might actually bring up, maybe even if you have an advanced directive and they kind of know you a little bit, or know you are someone that doesn't really want aggressive cares, they might say, well, actually, your heart's not the problem right now. I'm worried that your airway is going to be compromised first. Would you want to be intubated if we think you can, get back to breathing on your own? That might be the question they would ask you, and you could say, no, actually, I don't want to be intubated. That is not worth the risks for me. And so they would probably bring up that conversation at that point. Does that help?
I still don't figure out when that would be reasonable.
It's very patient specific, I would say. Yeah.
It's patient specific.
Patient specific. Mm-hmm. Yeah.
Some people are just afraid of intubation.
Yeah, and I think, especially at that point too, talking with your providers, there's actually risks to intubation. You say, oh yeah, well, I want to breathe, but you're sedated when you're intubated. You can't talk. Yeah.
But I could imagine a person saying that, you can hit my chest, you can shock me a little bit, and if that works, fine, but I don't want to be intubated.
Mm.
I could imagine that scenario. And the patient is the healthcare providers, and they get to make the call.
Yeah, and I would say, even to that point, a lot of healthcare facilities are moving towards, if you say, yeah, hit my chest, do all this, but don't intubate me, we're gonna make you DNR. Because we're gonna say, as a healthcare provider, I'm not gonna do kind of partial CPR in a way. If you're not gonna let me use all the tools in my toolkit.
That's what I would think.
Exactly. So I think that's why we don't, at Freighter, we don't allow just DNI and say, yep, you can do all the hard stuff, but don't stop at intubation. We don't actually allow that.
So at Freighter, they wouldn't even give you permission to have a DNI?
Alone. Yep, you can be DNR plus DNI, but you can't just be this on its own. Yeah, exactly.
So do we have research to show the results of what happens after DNI? So we have the research on the DNRs?
I'm sure it's out there. I'm not as familiar with it. But I think a lot of times again, we think, oh, it's just tube in, tube out, the ventilator will help me breathe for a little bit, but we know that there can be aspiration pneumonia. It can be hard to come off the ventilator. There can be a lot of complications from the time before you were ventilated. If your brain isn't getting appropriate oxygen, there could be some traumatic brain injury from that. So we know, and I'll show you a little bit of the research on DNR, but even then there are things that DNI is not, it's not an easy, procedure or treatment by any means. There are complications with it as well. Yeah.
This seems to apply primarily to heart attacks.
Yes.
What about a stroke?
Good question. I think a lot of these would be, so again, I'm not the medical person, but if a stroke were to lead to other complications, then this is where like, oh, yep, now your heart is in a dangerous rhythm, we're not gonna shock you. Or now you're having trouble protecting your airway, but you don't want to be intubated, we're not gonna intubate you. So a stroke might be that precipitating event that leads to a DNR. Good question. Yeah.
I have a question, perhaps you have covered it, but I'm not quite understanding it. We were told at one point that do not resuscitate could be broken into various types of things. Chest compressions, shocking, intubation, and so on. That you could rule out one or two of those things. As I understand that, that's not possible.
Not possible. At Freighter. At
At
Freighter.
Freighter, okay.
And most hospitals around the country. So I was actually, prepping for this talk, and we have lots of listservs. And again, unfortunately or fortunately, every hospital is allowed to do things a little bit differently and have a little bit different orders. But the national consensus is that's not good medicine, right? It's not good medicine to let patients pick and choose when frankly, patients, we don't understand, right? What's happening to us then, what we really medically need. And so again, that kind of goes back to that failure of a living will, where we're just picking and choosing and cherry picking. Oh, well, I don't think I want that, but that sounds pretty good. Like, put that in the bag. So I think it kind of is on our care teams to make sure we're educating you appropriately, we're giving you the risks and benefits, but we want to give you the whole picture. We are not going to say, yeah, there's definitely some risks of chest compressions, but epinephrine is not as risky, so we're going to do that for you. So I think providers are much better now at saying this is not good medicine to let you pick and choose. So here's what we would recommend and why. Yeah, a good question. Yeah. Joanne, and then back to you. Yeah.
So the opposite of DNR and DNAR is
Full
the
code.
CPR.
Exactly. We say full code.
Full code.
Full code. Yep. So that means
includes the DNR.
exactly. So if you're not DNR, you're full code, and I would say most people are, right? Like CPR is one of the interesting resuscitation efforts, are one of the interesting treatments where we presume you want it, unless you tell us otherwise, right? And around the country, around the world, really, we just presume you want it, and which I'll get to with the bracelet, unless you tell us otherwise. So most people in the hospital are full code, is what we would say. Yeah. So you might hear code status discussions. You might have had that with loved ones or surrogates. So when we talk about code status decisions, this is what we're talking about. Yeah.
I understand it's a 10% success rate, right, with the CPR.
I'm getting there. Yep. I got a slide just for you. Yeah.
I think this is really interesting, and it makes me think that, we grew up sort of with the new. I mean, the whole doing CPR and the crash code carts and all of that was developing when we were younger, and that now we have decades now of data and history and knowing what works. And I can imagine, being a nurse in the hospital, oh, no, that person wanted a partial code, or just this, or just that. You really, that's craziness, really. It's
exactly. And so I think you're right. It is relatively new, in this space. I'd say a lot of medicine is relatively new, right? But we're still figuring out the best way to empower patients to make the best decision. But sometimes, and especially I've seen this as a healthcare ethicist, sometimes empowering patients means taking decisions away, because the providers have knowledge that you don't, understandably, right? And so there's actually a phrase we use sometimes called informed non-dissent, where we're going to do this unless you tell us explicitly not to. Or we're not gonna do this because we don't think it's good medicine, and we're not gonna offer it, right? So I think we're getting better to that, because we were very paternalistic in medicine, then we kind of swung really far the opposite and said, patient gets to decide everything, and we realized that's not working either. So I think we're kind of swinging back into a really healthy and good middle ground, but we're still swinging a little bit. Yeah, interesting. But I want to get to, so some of the statistics, but even the bracelet, right? And I know we have our lovely Joanne here who had modeled her bracelet, and we actually have forms for those of you who are interested in this, but this is a way to say, if you were arrested outside of a hospital, where it doesn't say, DNR on your door or in your chart, if this is a really important value for you, this is a way to signal that to first responders. So this is legal and valid and recognized in the state of Wisconsin. Of course, we have heard that, sometimes first responders don't acknowledge them or don't respect them or ignore them. And I think that's certainly troubling, was one of the initial questions about precipitating this talk today. And so I could say, well, they should, right? And that's maybe not satisfying, because while they should be respected and they should be honored, but why aren't they? And I think, there's only speculation, of course, but first responders err on the side of life, right? They come to, and again, because CPR is opt-out, we assume you want it, and first responders go in assuming that everyone wants to be resuscitated. It's something we can do, right? We don't only err on the side of life, but we err on the side of doing something. It's very hard to say, she didn't want to be resuscitated, let's help her, keep her comfortable. I think that's actually very powerful, but difficult to do. This is my one little DNR story, which I don't know if you can have a funny DNR story or not, but I think another reason we're cautious, right, is because it's life and death we're dealing with. And so I wasn't involved, but I've heard the story many times of a patient who came in coding, and so they were doing CPR, full resuscitation efforts. He was middle-aged, and part of the process was looking through his wallet to see if we could find the next of kin, someone to call, his name, so again, we could start that process. So a nurse was looking through his wallet and said, stop, he's DNR, we need to stop resuscitation. But the team wasn't really sure, again, we want to make sure that when you say DNR, you really mean it. So they kept going. He actually survived and was resuscitated. They found out later the DNR card, or the DNR she had seen, was a Department of Natural Resources fishing license. And this is terrifying for family members who have DNR cards in their wallets, hunting and fishing licenses. So we take DNR seriously, right? I mean, I've even heard horror stories of someone who got a DNR tattoo, but it was a joke, or they didn't really mean it. And so we just really want to make sure, right? And so this is a great way to really make sure, this is official, something you order from the state. Again, it has your name and information on it. But in the heat of a moment, in the heat of a code, it might be hard to focus on that and say, yes, of course, we're doing the right thing by actually respecting their wishes as identified here. But I just share that story to say I think that's probably why people are, even first responders, even if they're trained, might still be a little bit nervous about that. So do with that what you will. But I do want to get into some statistics about CPR, some things you might not know. And again, this isn't to scare you or to make you want to get a DNR. I think, again, if anything from this talk, it's a chance for you to think about what you do and do not want. It's a chance for you to think about your own goals and values, and to talk about them with a trusted surrogate. I don't ever think that DNR is always right or DNR is always wrong. I think it really, I want to empower you to be able to make that decision for yourself. So of course you might know some of these physical complications, and I'll focus mostly on the CPR and even some of the shocks, but with elderly populations especially, we worry about broken ribs and breastbone from the compressions. We worry about bruising on the chest. You can actually get burns from the electrical shocks when they're trying to restart your heart. We worry about the brain damage from that lack of oxygen to the brain during that time. Again, the tube in your throat can actually cause a lot of complications as well. You can vomit during CPR and get pneumonia from that. And again, these are not always going to happen. Not all of them will happen. They happen to young people too. but I think sometimes the risks and benefits are different for a younger person with no comorbidities versus an elderly person with more frailty. So that's why people were like, well, yeah, I'd rather be alive and have a broken rib than be dead. But sometimes that broken rib is actually really complicating for people with certain frailty or certain other underlying conditions. A couple other, things you might think about from TV, right? So CPR works on TV, it's gonna work for me. The statistics, what do I do with statistics, right? So back to Joanne's question. Characters in TVs survive about 67% of the time. Actual survival rate is about 5 to 8%. Much, much lower than we see or than we think. I should have asked you all what you thought the survival rate was. They've done quite a few studies on this, of course. One study with an elderly group of patients, they predicted that their survival for 50%, almost 80% of them thought their survival would be 50%. 20 said, oh, survival is 90%. So about almost, all of this group thought their survival would be 50% or better, when in reality we know is between 5 and 8%. Here's another little breakdown. I thought this chart was really helpful, and apologies for those in the back, I'll kind of break it down. So it also depends on where you get CPR, if it's in the hospital or out of the hospital. So if you get CPR in the hospital, perhaps you already have an underlying serious illness, but if you get CPR in the hospital, 15 out of 100 will actually survive, leave the hospital, live an average of 4 months. 15 out of 100, so 15%. But this is, it shows you, all right, so that's good to know if I get CPR in the hospital. And again, this is a serious illness, so this depends on the person, on the patient. If you're getting CPR outside of a hospital, so in a residential facility, at the mall, somewhere like that, your chances are much lower of actually surviving discharge and living. So about 5 out of 100 adults who live in the community and get CPR, they leave the hospital and may live up to a year, 5 in 100. Adults living in a residential setting who get CPR and live, about 2 leave the hospital and may live up to a year, 2 out of 100 in a residential facility. And again, these aren't meant to scare you or shock you, but I think it's helpful to know, like, okay, where am I at, right? Like, what am I facing? What's my reality? Because we always are going to have my best case scenario. Like, I'm going to be the 2, right? And we're never going to get over that bias, and we want that bias, right? We're our own worst critic, but we're our own best advocate as well. And so I think, again, this empowering, we want you to be your best advocate and say, hey, actually, you know what? I don't have any underlying serious illness, or I am healthy at this point. But having these in mind, I think, is helpful when you're thinking about DNR decisions. There's also just a lot of good education that's being done, and some questions to think about. There was a study that showed a group of patients a video about CPR and mechanical ventilation. Just a 3-minute video, again, just giving them information. That group was 3 times more likely to have a DNR order than a group that didn't see the video. So again, we're not saying, oh, we want to educate you and then you're going to choose DNR, but I think it's like when the reality sets in, sometimes we just go, yeah, I just wouldn't want that. Like, I think I know what I want, but then when education hits, I know that doesn't make sense for me. So these are some questions to think about. Actually, more common misconceptions, I'd call them. My physician does not want to do CPR because I'm elderly. And I absolutely want to dispel that myth, because it's really not about age. It should be about your overall health, underlying conditions. You could be a really, really healthy 85-year-old, running, walking every day, and you could be a really frail or ill 60-year-old. So it's not about age, it's about your underlying health conditions. DNR means stop all care. Has anyone ever kind of heard that before? I think so often it's a I'm giving up. I'm just let me die. But actually that's not what it means at all. Because I think it's important to separate DNR from comfort measures, from hospice. These are all different things. You could actually still be receiving aggressive treatment and be a DNR order. So you could be, working towards maybe not curative, but you could be doing an aggressive treatment for a specific illness and still be DNR. Or you could be, all right, now I don't want to do any more aggressive treatments. I'm really just here to I want to be as comfortable as possible. So at that point, we would say we're focusing on comfort cares. But I don't like that either, because we always want to make sure you're comfortable, right? Like, I don't think as a healthcare team we're ever saying, oh, we're being aggressive now but not comfortable, and now we're going to be, really, really comfortable. But it's sort of the lingua franca that you would hear in the hospital. We're going to focus on comfort measures. So you could be DNR and comfort measures, but it doesn't have to be. All along, you should be focused on symptom control and goal-based care. And then, of course, that misconception of my DNR bracelet won't be respected. And I wish I could give more, like, yes, they should be respected. They're valid under Wisconsin law. Of course, hopefully, I'm just talking about a few of the reasons why they might not be respected, kind of gives you a little bit more insight. But I think it's a really good first step in saying, this is what's important to me. I'm wearing it on my wrist. And hopefully people will recognize that.
Are EMT workers responsive to the bracelets if you're out in the community and have a heart attack in the mall?
Again, they should be, right?
Okay.
That is
So they're trained.
They are trained to recognize them. And of course, when we hear the stories of, oh, they're trained to recognize them, but they don't listen, those are the concerning stories for sure. Even in our wellness committee, we said, well, if they don't respect it, could you sue? And of course, the answer is you can always sue. You just might not win.
Well, the EMT workers that I've known in my life are very responsible, caring people, so I would think that if they were trained to look for that bracelet, they're gonna look for the bracelet.
Right, exactly, and that's what, common sense says as well. And so I think the only caveat would be, again, if too much is happening and I didn't see it and they err on the side of life, that's maybe why it would happen. And of course, you can sue as well, if that happened, but I think the likelihood of winning would be low, just because they're EMTs, they want to save lives, right? So I think it'd be hard to win that, if anything. Yeah, but good question. And then of course, I'll let my family decide. I think that's the biggest misconception, that we think is actually helping our families, but maybe it's actually harming our families. All right, so I know we're at 2, but I'd love to just have a little bit of conversation if you have a few more minutes. I'd love to hear how many of you have had these conversations with your families and friends and surrogates? Yeah. So I'd love to kind of take a minute, maybe talk to a couple people around you, and then I'd love to hear from the larger group as well. But how did you approach this conversation? Maybe not even specifically about DNR, but just your end of life wishes. What went well and what didn't go so well? Or maybe I chose a surrogate that my family didn't agree with. Or something like that. So yeah, just take a minute, maybe with those around you. I'd love to kind of get your collective wisdom, and then we'll report back and share what has worked well or what hasn't when you've had these conversations.
I have one other question. How does this influence making a 911 call?
Good question. What do you mean?
Well, when I knew my husband needed to go to the hospital, I called the ambulance and I said, this is not an emergency. I don't need any lights or whistles or sirens or anything. And so it was, but if I had just called 911, I think they would have come in and started.
Yes, that is a great conversation probably with your healthcare providers as well. When should I call 911? When shouldn't I? And also I deal a lot with parents, especially with kids who have trach vents, and they're trained to handle this, but in an emergency, your instinct is to call 911, right? And so I think it's being comfortable in the uncomfortable a little bit, saying, okay, I know he needs to go to the hospital, but I'm not gonna call 911. You have to just kind of be certain in yourself and have that presence and awareness of mind to say, okay, take that pause, take that breath. I'm not gonna call 911, but it's hard to do in the moment, I would say. Yeah.
That is something that should be clarified with the staff here.
Yeah, great question.
Because I needed an ambulance and I didn't know whether I should be calling 911. I think that was suggested to me,
Right.
and I never thought about the implications of 911 versus just a fast ambulance.
Yep, that's I think a great question for staff, and we can kind of keep a list, maybe the wellness committee can keep a list of follow-up questions, but exactly, based on your circumstance, your wishes, what kind of response do you want? I think that's great to have that plan in place.
Doesn't the DNR choice usually happen right in the hospital when the patient's already sick?
It does. It definitely does usually happen. That's when, again, that code status conversation would be happening and saying, okay, your loved one is really sick at this point. We don't think chest compressions would help him restart his heart. We think he should do not resuscitate. That's kind of how the conversation would go with the surrogate or loved one. So I'd say that's absolutely where it most commonly comes up. So a DNR out of the hospital is certainly not as common. I would say, I don't actually know the percentage of people who have a bracelet, but it's low. It's certainly low, and so that's like a really deciding factor. Like, oh, I'm so sure that I want to wear this bracelet. I think that just speaks well to how you've thought through your values. But it's certainly by no means I'd say the majority. Yeah. Do you have a question here too? Or comment?
It was something about 911.
Yeah, yeah.
What's your alternative?
I haven't had any problem with calling 911 and telling them I don't want the siren on or.
Right. I think there are non-emergency numbers that you can call, and again, that's a great question for staff
They always
here.
call them here.
They always call 911. But yeah, you can specify too, like especially if you call 911 but say, hey, remember, she's DNR, or we don't actually want resuscitation, but they may say like, well, then why'd you call us?
Yeah.
Right? But sometimes like we call because we don't know what else to do.
Yeah.
We call because that's what we do. We call because we don't want to be alone. Right? So I think there's a lot of reasons why it makes sense why we call 911. It's hard to be in that moment where maybe your loved one is having an arrest and they don't want to do anything and you just hold their hand. I think that's a powerful moment, but hard to do until you are there doing it.
Are you aware of what happens when we call 911 here?
No.
A fire truck shows up
Yeah.
with all these heavily dressed.
That's why you just call it.
And I think
Just
that's
call it
why,
ready, yeah.
exactly, and I think that's why, I had this The Lost Art of Dying, because dying is an art form, right? Do you want the drama of the fire trucks and the sirens, or do you want that quiet stillness? And sometimes you don't get to pick that, right? You're out of it maybe, but what do you want for your loved ones? Or what do you imagine that for other people that you care about? And I think it's a hard decision to talk about and think about, but neither one is right or wrong. Absolutely some people want everything, and we want the fire truck to come, and we want it all. And sometimes we want that quiet stillness too. Joanne and then right here.
So should we be looking for private ambulance services? Then, like the big run ambulance?
I mean, you could. I worry about financial implications of private ambulances. So I think it's certainly fine to call 911 and say, hey, this is what I want, this is what I don't want.
Oh, okay.
Right? I think if you have that presence of mind in that moment, if you're the one calling, as I think some of you mentioned too, like, oh, we can do some of that. I think that's fine too. Right here and then.
Is there any good reason to have the fire truck come?
I don't know.
I heard that was something to do with labor regulations in that, in the fire rescue, that it has something to do,
Okay, I don't know.
It's not just that they want to send fire trucks out, but it's something to do with this, with staffing and.
That makes sense.
It was police and then
No, you're fine. I think it
the
probably
fire
is.
departments took it over.
It
That's
could
what I
be
always
just,
thought.
I think it's just because they're trained first responder, they're trained EMTs. So if they are available, I think we're actually getting them for their healthcare abilities more than their firefighting skills.
Right.
But that is what they're also trained to do. So that's probably why they come. And they're quick. And they look good doing it, so we won't complain, but.
Well, there's different kind of trucks too.
There's first aid
You
trucks.
don't carry guns.
Yeah, so there's maybe benefits to the fire
I
company.
remember once,
If you read in your resident handbook, it's outlined there what to do when it's an emergency, and you can always call, push your help button, or call the desk downstairs to get a nurse to come over. If you're not sure about if you obviously know this is an emergency, or your spouse knows this is an emergency, call 911 first.
Yeah, yep.
And then you can call the desk, because then that person can come over. Also, that person that comes over, that nurse will, I recommend that you get a non-emergency trip to the hospital. You know, do you have a way to get there, or should we call an ambulance?
Exactly.
So that can help you.
Exactly, and
make that
sometimes too, it
decision.
can be emergent to make you comfortable, right? Like we
Yeah.
don't want to resuscitate, you don't want resuscitation, you don't want to be intubated, but we want to make sure you're comfortable. And first responders can help in that comfort process too. So that might be a reason why you call 911, even though, nope, I'm DNR, please don't, do CPR. But even the emotional comfort of having someone there, but they can also do, physical things for comfort as well.
And I think that this is an opportune time to say, we redid the resident handbook. There's a new version that just came out. Remember, you got your books. But when the Lakeside Terrace people start moving in, that we will update it again. And so if you'd all look in the handbook, and is that clear to you? Is it clear to you what's in the handbook? And if it's not, just call me, let me know, or Joe Schmidt, because she's on the communications committee that is actually doing that. Then we need to make it clearer, so that you have information about how to do that
And
process.
do it ASAP because the process is starting.
Yeah.
I'm not clear
Yes.
about, if you're dying, why can't you just be left alone to die?
You can.
But you can.
You can.
You can.
Is that any kind of legal issue for the spouse?
No, I think it's just, we're bad at talking about death. We're bad at talking about dying. It's uncomfortable, right? But I think that's,
afraid of dying.
Absolutely. And I think that is why talks like this might feel scary or sad, but I hope it's more about, it's okay, right? If it's just me, or if it's just me and my spouse, or me and a child, and just hold my hand, right? There's something so powerful in that. But that's not for everyone. But I think if you can come to terms of, that is what I want, take that. I hope you feel empowered to tell someone that, and to share that with someone, even if it's scary. But there's certainly it's not illegal to die alone.
Mm-mm.
Yeah.
What if your surrogate is not close by?
Physically, not physically close by.
Yes.
I would say make sure they're, not like waiting for the phone call, but reachable, right?
Okay.
You want to make sure they're reachable. Not that we, anticipate
In
anything's
other
going to
words,
happen.
they don't have to be there in person.
They don't have to be. No, we do a lot of phone calls.
Okay.
A lot of even face with.
Okay.
We're so good at FaceTime and Zoom now. So yes, they don't have to be local. Yeah. Other questions? Yeah.
You have forms to fill there.
Yeah. So these are if you're interested in.
I have a
bracelet.
DNR that's many years old,
Okay.
but it doesn't have my name or anything.
I think yes. These usually, like Joanne, yours has your name on it, right?
I can't read, so I don't think it is.
Oh, no, it says in your choice.
The back.
Yeah, so I think you're good.
I'm good to go.
Yeah.
I can die.
So I
More
know,
ways than one.
I know we're at
How
time.
quick do you wanna go?
So a couple of resources. Here is a snippet of a 5 wishes document. So it's a type of advance directive you can fill out. And again, I'll send these out. But these are great ways to start talking about death with your surrogates. We call it Death Over Dinner, Death Cafe. These are all online. I've done Death Over Dinner with my undergraduate college class, and they said, I loved it. We had pizza. We talked about, what it would mean to die well, what it wants.
It's because of the pizza.
Just eat pizza. Everything is better.
And
But
if
just-
you eat enough of it, you're gone.
Exactly. It helps lighten a heavy topic, but it's so important to talk about. And then again, I'll end with I love this quote from, here we go. This is a book that I really recommend, and thank you, Joanne, for the prompt, The Lost Art of Dying, by Dr. Lydia Dugdale.
Why is it an art?
Why is it an art, right? Because she calls
And
it,
why is it lost?
she says we're bad at it, so that's why it's lost. And it's an art because it's hard to do it well, right?
Well, did they ever do it well?
She says we have. There's been there's rituals, there was meaning around dying that we sort of have lost, I think. And she does a really good job of kind of the history of it. But I think this quote sums it up really well. She says, the body withers and fades. This is surely to be expected. But we're not without resources. Existential, ritual, practical, you could add in, religious or spiritual. I think those are important as well. And as we walk together toward the fear and the sadness, as we sit low to grieve our own dying or the death of others, we may find ourselves transformed in the process. The transformation is not from sickness to health or from death to life. Rather, it is the change that comes from experiencing the profound. We grow wiser, more whole. We discover calm in turmoil, light in shadow, beauty in decay. And I think that, for me, says it really well, where it's not about, progress for progress sake, or health for health's sake, or living more just to live longer. But there's actually something beautiful about the transformation. And maybe you're like, oh, this is a bunch of schmooey, right? Death is bad, right? Death is death. And that's okay too. I think at the end of the day, death can be hard and sad and beautiful and good and complicated and messy and all of those things all together. And so that is what I have for you. But again, find a surrogate, talk to them. And if you don't have a trusted surrogate, maybe look around. This is maybe a trusted audience of people that took time out of their Tuesday to come talk about death. So I think that's actually happened before at a couple of death cafes where they didn't really have a friend or a family member. So they were able to find a neighbor who would make the decisions that they wanted to make. So they started having coffee and found a surrogate. So find a surrogate, start talking about your values, start thinking about what you would want, and know that it's all part of living well. So I'll leave you there. Sorry, we went a little over, but I'm happy to stay for other questions. If any other questions or thoughts or comments?
Did it ever come up that money was a factor?
Oh, I'm sure it has been. In death and dying, we know money, causes a lot of problems.
Mm-hmm.
Do you mean in terms of family conflict or family conflict? And I also think, I don't have money to pay for this, so I'm just going to die, right? Or in treatment sense as well. We don't face that as much now, but I think we're facing that a little bit in terms of, I'd rather die at home, but I can't pay for nursing care or something like that. And so then I end up dying in a hospital, which maybe I don't want. So I think money is certainly a factor to an extent. Yeah.
And it's also knowing and not being afraid to ask, or, is hospice an appropriate choice?
Yeah,
so that,
absolutely.
So
and
that
again,
you have more of that opportunity to plan and have the death you want.
And so much of it is, again, we're not, healthcare, we don't want to say, palliation, even palliative care people still think is hospice. It's not. You could actually, again, be doing chemotherapy and palliative care. Right. That's actually standard protocol now at Children's. And so it's just kind of uncoupling, what we think we know about death or dying or being comfortable, but it's, I can be doing aggressive treatment and BDNR. I can actually be doing aggressive treatment and palliative, or I can go into hospice, but I could be living, I could live another 6 months. So it doesn't mean I go into hospice and I die the next day. I think there's still some of that too. There's just so much that in our minds and our culture, we cling to these ideas of what death is or what it looks like, or these notions that we have, like, I go to hospice and then I die. There's actually so much beauty in hospice, and there's been some really wonderful studies and some work that shows just how wonderful these facilities are too, or in-home hospice, or all the memory making that can happen. It's hard to talk about.
When you say dying is really a part of living, because it's a part of our life, a continuum. And the thing is, in some states, you can plan your death in advance.
Right.
And I don't think in Wisconsin you can do that, right?
Yes, that'll have to be in the next talk. So there is no aid in dying in Wisconsin. That is, I think we're at about 14 states. It's legal medical aid in dying, or you might have heard physician assisted suicide is legal in about 14 states. So
11.
there is. Oh, is it 11? Yeah.
And counting
DC and yes. And then there's a couple states that it's not illegal. I would say so, like Montana. There's not a law, but it went through the court system. So a couple like that.
That's included in the 11.
Is it included? Okay.
Yeah.
Thank you.
Canada and New Mexico.
Yeah. So we are not there yet as a state. But I think the biggest thing we can do is there's still ways to make you comfortable. It doesn't mean if you're not getting it doesn't mean if you're not getting CPR, we're just gonna let you wallow away. We are gonna make you comfortable. We want to make for your family, for your surrogate, for you. It doesn't.
How much morphine can you take to be comfortable?
Depends on the person.
Yeah.
Depends on the person. Yeah.
People have figured out how much it takes to die and collected, you know.
So, yes,
Do you have suggested books or readings on the difference between palliative care and hospice? There are so many confusions.
Yes, I'm trying to think of a good book. I
Or
can't think of.
listing of facilities in southern Wisconsin.
I do not have that list, but I can send some to the wellness committee and maybe we can get a list to you. But I would also, two of them that I'd recommend, the Institute for Healthcare Improvement. So they don't have a list per se of facilities, but they do a great job of talking about hospice, palliative care, what's the difference. And then even the Wisconsin Medical Society. So they have, advanced care planning website, advanced directed by the Wisconsin Medical Society. So they have some resources, very extensive and specific to Wisconsin, that talk about advanced care planning. They actually have some great videos from different faith communities. So if you're Catholic and you want to know what does it mean to be Catholic and to choose DNR or exactly. So they actually have, I think it was, I can't remember who it was in our, who was doing the videos, but someone, kind of a leader in the Catholic Church in Southeast Wisconsin made a video series and posted that on the Wisconsin Medical Society webpage. So I'd say that's a great place to start for a couple of resources as well. But then I'll also see what I can find. I think palliative and hospice, I'm trying to think of a good book for that, but I think, these are a couple of good places to start, and I'll see if I can find any others, but great question,
That might be something that wellness committee, we maybe want to address too, is have a presentation about, this is hospice, this is palliative, and, what kind of decisions.
Presented by a palliative doctor at Friedert, a woman.
Okay,
I don't know if you've met her yet.
do you know her name?
Ask me my ways.
One thing I would recommend, it's not really about palliative or hospice, but it's called In Shock by Rana Awdish, Awdish. She was an intensive care physician who now does palliative. She actually just spoke at a palliative care conference in Geneva that I was at last week. But she had a near-death experience. And some things really did not go well. And so it's kind of critical of the healthcare system in general, but also highlights the benefits of palliative care, and talks about, how do we face our own mortality, especially as an intensive, intensivist physician, coming kind of face to face with her own mortality in shock. So that's if you're interested in kind of those first person accounts of what it means to, come face to face with that, that's a really interesting read.
What's her last name, please?
Awdish, Awdish.
And what is the name of the book?
It's called In Shock. I think there's a subtitle, but I can't remember what comes after the parenthesis. But In Shock is a great one.
And what is the relevance of Elizabeth Kubler-Ross today? I remember years ago.
Stages of Grief.
We all read that and talked about it. And what was that, 30, 40 years ago? We were at very different stages in our
50
life,
years.
and I
Yeah.
haven't heard her mentioned in some time.
So interesting that you mentioned that. Actually, she came up at the palliative care conference because there's sort of a pushback. So we don't come to terms with death or grief. Usually the death of a loved one or maybe our own diagnosis. We don't do that in grief. In stages, it's messy and we bop back and forth. So there was actually quite a bit of pushback in the early stages. Now there's new research coming on that there was actually a grief researcher at this palliative care conference, and she said, no, actually, these stages are quite accurate. Not all at the same time, not all at the same pace, not all in the same order, but there are clearly moments of anger, denial, until we find, bargaining, until we actually get to that acceptance. Because her work at this speaker was talking about disenfranchised grief. And prolonged grief disorder, which we know is now in the Diagnostic and Statistic Manual for mental illness. So that's another conversation of prolonged grief disorder. But she's saying, yes, there's sort of normal grieving process, and there's maybe abnormal grief that we would seek help for. And so she was actually talking about these stages in terms of that. So I think they're still relevant, actually. I don't think it's a prescription. I think that's the pushback, right? You don't have to feel depressed and then angry and then bargain. Grief is grief. Grief is messy. Grief is complicated, and grief is really personal. And so I think that's the pushback on her. Just saying, if you're never angry and you're just always sad, you're not doing grief wrong. I think that's the point too. Like, don't should your. I love the phrase, don't should yourself. I should be doing this. I should be doing that. It's just grief is grief, and let yourself grieve. Yeah.
And sometimes you might want to contact various hospices because some of them will offer grief counseling like group, or they will just offer various sessions that will deal with grief in different ways, and those can be very helpful.
Yeah, so at this palliative care conference, we were doing a session on surrogate decision making for when the surrogates disagree, what do you do? And a lot of the strategies that we talked about were actually supporting either the named surrogate or the surrogate who disagrees. Grief counseling was actually a main factor in supporting them. So obviously communication, giving them time, but we want to support, again, that goes back to that family-centered care for these surrogates that disagree, or the one who's not the legal, but we still want to support them. Grief counseling was actually brought on, not for the patient, but for the family, and was really helpful.
Yeah, I would think so.
Yeah. Questions, comments? Well, it sounds like Wellness Committee, you have a lot to add to your agenda, which is great. Thank you all again so much for being here. Wonderful. Anytime.
Climbing into the left.
Thank you.
Thank you.